Cancer Kids, Strain of Smiles, Doctors Network, Maharashtra. And the topic of today's session is liver tumors in children. So let's begin today's session, for which I would like to invite Dr. Monica Bhagat ma'am to take over. Please proceed, ma'am. Thank you so much.
Dr. Priti, you'll have to allow me to share my screen for a while. Yes, thank you. मैं इधर ही हूँ. Okay. Good evening, everyone. Welcome to our platform, CancerKidsSOS. And as Momita was proud, I'm also proud. We have completed 1 year and we had good number of lectures having a MDT team. So, and also I would like to welcome our executive members for next year. We have Dr. Pankaj Dwivedi, who is consultant in Pediatric Oncology from National Cancer Institute in Nagpur, Dr. Nirmali Pradhan, who's consultant pediatric oncologist and hematologist, and a BMT physician from Bakshi Sri Shankara Cancer Center in Bhubaneswar. Dr. Prasanna.
Slides are not moving, Monica.
Slides are not moving. Okay.
And full screen bhi nahi hai.
Okay, I'll do it again. I'm sharing again. Just 1 second. Is it visible?
Yeah, visible, but make it a slideshow.
Is it okay?
Yes, it's now.
Okay, so thanks, you reminded me, because I wanted to show my executive members, which I'm proud of. So we have Dr. Pankaj Dwivedi, who's a consultant pediatric oncologist from National Cancer Institute, Nagpur, Dr. Nirmali Pradhan from Bakshi Sri Shankara Cancer Center in Bhubaneswar, and Dr. Prasanna Kumar, who's associate professor in pediatric surgery from St. John's Medical College and Hospital. So they'll be with us, helping us, supporting us, guiding us what has to be done. And we have some plans. We'll be sharing it as the time comes. So coming to today's talk, we are going to have a topic discussion on liver tumors in children. We'll be talking about the understanding of pediatric liver tumors, insights to the liver resection. We have 2 surgeons with us. Complicated liver resections and liver transplant, liver transplant would be covered. So to introduce, Dr. Priti Mehta is a senior pediatric oncologist in SRCC Children's Hospital. She's done her fellowship in BMT from Great Ormond Street, Newcastle. She'll be talking about approach to liver masses in children. We have Dr. Sajid Qureshi. He is professor and head of Pediatric Oncosurgery in Tata Memorial Hospital. I don't think he needs any introduction, but yes, he'll be talking about liver, understanding liver surgeries and fundamentals and techniques about it. We have Dr. Ashok Thorat. He is a senior consultant in hepatic surgery and liver transplant in SRCC Children's Hospital. He is given around 8 to 9 years in Taiwan, where he has done his fellowship in hepatobiliary surgeries and liver transplantation, and is done masters in hepatic surgery and liver transplantation. He'll be talking about time and role of liver transplant for these liver tumors. So over to Dr. Priti. I'm stopping my share screen.
Good evening, everybody, and I thank Dr. Monica and the Cancer Kids SOS team for inviting me to talk today. And thank you for my introduction, Dr. Monica. So I work at SRCC Children's Hospital as a full-time consultant, and my topic for today is approach to liver tumors in children. So we know amongst the abdominal tumors, after neuroblastoma and WINS, the commonest is the liver tumors. And out of the liver tumors, hepatoblastoma and hepatocellular carcinoma, they account for practically 2/3 of all hepatic neoplasms. However, we should not forget that there are even benign liver tumors like hepatocellular adenomas, hemangiomas, hematomas, and focal nodular hypoplasias, which should be kept at the back of the mind, because 30% of the liver tumors in children are benign. So when we look at the age-wise, when a child with a liver mass comes to us, you can feel that liver mass. You have to decide clinically as to what you are dealing with, and that age criteria really helps us to an extent in deciding what type of tumor would we be dealing with. So if we look at children in the first 3 years of age, amongst the benign variety, we have the congenital and the infantile hemangiomas and the mesenchymal hematomas. And the hepatoblastomas also predominate in the first 3 years of life. If we are looking at an older child beyond 7, 8 years of age and going into adolescence, then undifferentiated embryonal sarcomas, which is again a malignant tumor, should be kept in mind. The adolescent girls especially are known to have focal nodular hypoplasias and adenomas, and hepatocellular carcinomas is again an older age group tumor. So this is a rough guide of what I just talked as to in the first 3 years. If we are thinking of benign tumors, we are dealing either with a hemangioendothelioma or a mesenchymal hematoma or a teratoma. And if we are talking of a malignant component, then a hepatoblastoma predominates. However, rhabdoid tumors, yolk sac tumors, LCH, megakaryoblast leukemias, and many others like inflammatory myofibroblastic tumors should be kept at the back of the mind. And as I said, in adolescent, the benign ones would be adenoma and focal nodular hypoplasia, whereas Hodgkin's, leiomyosarcoma, and hepatocellular carcinomas or embryonal sarcomas, they are usually seen in the later part of childhood. So how would a child with a liver tumor present? He would present with abdominal distension, a palpable abdominal mass, or would have both. The CBC wise, you would see anemia, you may see thrombocytopenia, leukocytosis. And if the child has presented as a fetal or a neonatal presentation, then hydroamnios, fetal hydrops, congestive heart failure, or respiratory distress could be one of the presentations. Now, how do you evaluate a liver mass? First of all, you want to verify the exact location. So an ultrasound is very handy to do that. But then you need to characterize it further with a CT or MRI and a chest X-ray to see if the lung parenchyma has been involved, if there is any malignant tumor. CBC, your basic CBC and tumor markers like alpha fetoprotein and beta HCG for a liver tumor are important. Not to forget, a family and a birth history is very, very important. Now, when we talk of the tumor markers, alpha fetoprotein, it is usually elevated in more than 90% of hepatoblastoma cases. And it may also be elevated in hepatocellular carcinomas and malignant germ cell tumors. However, even benign tumors like mesenchymal hematomas and infantile hemangiomas would have an elevation of AFP. But that's much less compared to what you would see in a hepatoblastoma. So in hepatoblastoma, you usually see in lakhs or something. And once you start therapy, then it returns to normal, and its half-life is approximately 7 days. It's a valuable, so even after hepatic resection, it's a valuable surveillance marker in children with hepatoblastoma. But then there are age. Usually the AFP comes to normal up to 6 months. So there are nomograms. So we need to be vigilant, and they are available on site. So you need to compare the AFP levels with the age-related values to say whether it is elevated or not. Next is beta HCG. It's a hormone commonly expressed by liver tumors and may result in precocious puberty. Of the liver has divided these liver tumors either into the epithelial variety or a mesenchymal variety or a biliary variety. Now, hepatoblastomas and hepatocellular carcinomas, they both fall into the epithelial variety. And hepatoblastomas of the epithelial variety are further divided into the pure fetal histology or an embryonal or a small cell component or a macrotubular or small cell undifferentiated. The biliary ones are the bile duct adenomas or the cholangiocarcinomas. Benign varieties like the hepatic hemangiomas or the mesenchymal hematomas, which we talked about, or they could be malignant like rhabdomyosarcoma or embryonal sarcoma. So hepatoblastomas are also known to be of the mesenchymal variety, and they can have a mixed component also. Tumors of uncertain origin like malignant rhabdoid tumors, germ cell tumors, desmoplastic, they come as the of uncertain origin. Now, when the child comes, which tumors do we biopsy? So tumors that are not clearly benign or resectable at diagnosis, the recommended approach is an image-guided coaxial core needle biopsy with embolization of the biopsy tract. And this I will leave it to the surgeon, Dr. Qureshi, to expand further because that would be his domain. Now, as I said, there are 30% of tumors which are benign, like the hemangiomas, the hemangioendotheliomas, which are vascular in origin. So I will just describe a little bit about the benign tumors before we go into the malignant variety. So we know that hemangiomas are usually occur in the first 6 months of life, and it's the most common benign liver tumor of children. It has endothelial lined vascular spaces. And hemangioendothelioma, it's a subtype of hemangioma. There's always a female preponderance found in these
Dr. Priti, your signal is bit.
Clinically, if you look at the CT scan, this is how the tumor is. Is my voice breaking?
Yes, yes.
Hello?
Yes,
hear
in
me?
between.
Yeah. Sorry. So a hemangioendothelioma or a hemangioma would have a peripheral enhancement on the CT scan, and that would that this is a hemangioma. Clinically, 10% of these children also have cutaneous hemangiomas, and that will help you in predicting whether this is a hemangioma or not. Usually in the younger age groups, 50% of them present with high output cardiac failures at initial presentation. And the CT scan, as I showed you, it will be an isodense filling of the lesion with a peripheral contrast enhancement. Lab abnormalities would be the normal things like anemia, your LFT is deranged, Billy is deranged, and you may get an elevated AFP level, but it's not going to be like hepatoblastomas. These children can also have platelets registration and consumptive coagulopathies in some of these children. But if they have any of the complications like a platelet consumption or coagulopathy or a cardiac failure, then you will need to address that. And for that, you would give them high-dose steroids, which is administered over 3 to 5 weeks, and then gradual tapering. For cardiac, digitalis diuretics would be required. You need to correct the anemia, the coagulopathy, and propranolol has also been used. And we can also give interferon alpha, which has been tried in the children at 3 million units per meter square per kg, which may lead to an involution of the hemangioma of the body. Next, benign tumor is mesenchymal hematomas. It's usually rare tumor, but can present in the first 2 years of life. It may, during the initial period of first months, it may grow, then stabilize, it may regress. These tumors are more common in the right lobe of the liver, and they are often multicystic, heterogeneous, confined to one lobe, and asymptomatic. So when you get a palpable mass with smooth borders and a venous engorgement, probably this is a mesenchymal hematoma. And you get multiloculated cyst with solid septae. But if the cysts appear less cystic and more solid, then you need to be worried about a malignancy and you need to biopsy these. The treatment would be enucleation, marsupialization, or complete surgical resection. Focal nodular hyperplasias and hepatic adenomas, they require an estrogen environment to grow. And so these tumors are more seen in the adolescent girls. So if you have an adolescent girl who comes with tumors, these should be there at the back of your mind. And you need to differentiate the focal nodular from adenoma by doing a technetium sulfocolloid scan. Why? Because focal nodule hyperplasia lesions, they are often asymptomatic and have no malignant potential. Unlike the hepatic adenomas, they have a malignant potential. They have a small risk of rupture. They can have hemorrhage, and they can transform into hepatocellular carcinomas. And so we need to be a little more aggressive when we have a hepatic adenoma. So this is a picture of the hepatic adenoma that is seen, and this is the intraoperative image which Dr. Qureshi. Yeah.
Dr. Priti, I'm sorry to interrupt you again. I think there's some problem with the audio. If you could stop your video, probably that would help. I mean, this is just a suggestion, but there's some with the audio.
I don't know. I am not able to stop my video.
Okay, chalega. You can
Okay,
continue.
I have done it. Okay.
Yes.
So this will be shown by Dr. Qureshi again, the hepatic adenomas. My slides have stopped moving.
You can try resharing it.
Yeah, okay. So I have finished with the common benign tumors that we see in children. Now we come to the commonest malignant tumor, and that is hepatoblastoma, usually seen in the first 3 years of life. And it accounts for 2/3 of all pediatric liver tumors in children. As discussed initially, it can be an epithelial variety or a mesenchymal variety, or it can be a mixed variety. Amongst the epithelial hepatoblastomas, we have 5 varieties, which may be fetal, embryonal, small cell undifferentiated, cholangioblastic, and macrotubular. This is very important. The histopathology is very important, which I will tell you later as to why we need to know whether it is fetal or embryonal or small cell undifferentiated. If we consider imaging, a triphasic CT of the chest, abdomen, pelvis with contrast is still the gold standard in our country because we lack hepatocyte specific contrasts. Now, when we look at the pretext and the post-text staging in this children, by pretext what we mean is pre-treatment extension of the tumor and post-treatment extension of the tumor. And this is very important. And this is very, very important that it is reported because that's how we are going to be staging these children and treating these children. And in case we have done an MRI abdomen and pelvis, then it is better to do a CT of the chest to look at the metastasis if it's happened or not. We should be very clear that by post-text, we mean staging after our neoadjuvant chemotherapy and not after the surgery or the resection. There are 2 cooperative groups as far as hepatoblastoma is concerned. One is the SIOPEL group, which is a European group, which believes in giving pre-operative intensive chemotherapy to improve the surgical resection and then after surgery give post-op therapy. Whereas the North American, that is the COG group, believes in upfront surgical resection whenever feasible. Now, in hepatoblastoma, it is not mandatory to do a liver biopsy to biopsy the tumor unless the child is less than 6 months old, is older than 3 years old, or has a serum AFP, which is normal. Otherwise, if you are not falling into this and have a high serum AFP, then you can safely not do a biopsy in these children. As far as the Americans are concerned, the Children's Oncology group, they go according to the surgical resection. And if it is a metastatic disease, it is high risk as far as COG is concerned. But in the SIOP group, they believe in the radiological staging of the children. So the Conant's classification has divided the liver into 8 segments. And each segment is functionally independent, having its own vascular inflow, outflow, and biliary drainage. And so it has divided it into right anterior and posterior and left medial and lateral segments. And this is how the segments are numbered, which the surgeons will, which help the surgeons as far as sections are concerned. So now when we talk about the pretext staging, stage 1, there are 3 contiguous sections which are free. So if we look at this diagram, the first one, the stage 1, where you can see the liver is divided into 4 sections and 3 contiguous of them are free. In stage 2, there are 2 contiguous sections which are free, as depicted in all these 4 sites. In stage 3, it is 1 contiguous section which is free. And in stage 4, there are no free sections. Apart from this pretext staging, there are certain annotation factors and which are which are depending on the imaging analysis, they are considered positive. So if there are all three hepatic veins or the IVC involved, or there is a tumor thrombus, then it's given a stage of V, then there's an annotation factor of V+. If it is involving the main portal vein or the bifurcation, or there is a tumor thrombus, it is known as P+. If there is contiguous extrahepatic spread, it is known as E+. Multifocal disease is F+, and something that the tumor, if it has ruptured, it becomes R+. Whereas COG staging is a surgical staging, where on stage 1 there is no metastatic disease. In stage 2 there is microscopic residual disease or there is a tumor rupture. Stage 3 is a gross residual disease, and stage 4 is distant metastasis, irrespective of the local extent of the tumor. So when we compare the COG and the SIAPL has put only two groups of risk stratification. One is the standard risk and one is the high risk. The standard risk, the tumor, any pretext 1, 2, 3 comes as standard risk. The AFP should be more than 100 and the tumor has to be confined to the liver. Whenever you have pretext 4 or you have any of the annotation factors or an AFP less than 100, it becomes a high risk. Whereas in COG, there are 4 risk stratifications. There are 4 categories. So in COG, they've said the very low risk is the stage 1 pure fetal histology hepatoblastoma. And that's where our histology comes into picture, which I was talking about. High risk is any stage 4 or any stage when the AFP is less than 100 becomes high risk. Stage small cell undifferentiated, stage 1 or 2, or any stage 3 becomes intermediate risk. And whatever is remaining after all this becomes low risk. And that is stage 1 non-pure fetal histology or non-stem small cell undifferentiated, or stage 2 non-small undifferentiated. So to improve the results, there is a Pediatric Hepatic International Tumor Trial, which is a cooperative trial, a joint consortium by COG, SIAPL, and the Japanese group, which have stratified into, again, 4 risk stratifications like very low, low, intermediate, and high to improve the prognosis for these children. And this is a comparison of the use of pretext, very difficult to remember. Most of the times we follow the SIAPL, which is like divided into just standard risk and high risk, which is easier to remember. And it's, I mean, I'll have to refer to the chart if I have to use any of those other staging systems. Now, if we talk of the chemotherapeutic agents for hepatoblastoma, cisplatin, carboplatin, vincristine, doxorubicin. These are known to be highly effective in hepatoblastomas. So when we define the tumors according to the SIAPL, there are standard risk tumors, high risk tumors, and very high risk tumors. As I said, standard risk tumors are those with pretext 1, 2, 3, with no additional adverse features. There is no low AFP, there is no vascular involvement, no extrahepatic spread, tumor rupture, metastatic disease. So when all this is absent, it is a standard risk tumor. Whereas high risk tumors are defined as those tumors which are neither standard risk nor very high risk. And for that, we need to give superplado. Very high risk tumors are when there is a metastatic disease, usually to the lungs, or the AFP is less than 100, it becomes a very high risk tumor. Now, how do you define the pulmonary lesions? So you document either on the chest X-ray or on the lung CT, and you consider them to be metastatic if you have one nodule larger than 10 millimeters, or you have several nodules with at least one larger than 5 millimeters. So the SIAPL-3 study was a randomized study to look at the results of using 4 cycles of chemotherapy. Either they used single agent cisplatin or plado, where they used a combination of cisplatin with doxorubicin. The only thing was that the regimen, the cisplatin monotherapy was given every 14 days, whereas the cisplatin and doxorubicin was given every 3 weekly. And then a surgery performed and then 2 cycles given later. And what they found is that the overall risk between the single agent and double agent was not different, and so was the event-free survival, showing similar results. And so it was concluded in the SIAPL-3 standard that single agent cisplatin is not inferior to the combination, that is the plado therapy, for standard risk hepatoblastomas. But it was not good enough for the high-risk hepatoblastomas, and so they did a super regimen where they altered cisplatin cycles with carbodox, and that was given every 2 weekly. And 7 cycles were given, and after the end of 7 cycles, the child was assessed for a delayed surgery. If surgery, post surgery, there were 3 cycles given. Cisplatin was given at 80. These are the doses that was given. You can get it. I will not go into the details of that. And as I said, the response was evaluated at cycle 2, cycle 4, and cycle 7. And cycle 7 was when it was decided whether the child could go for surgery or not. And the definitions used were a CR, a PR. CR was no evidence of disease, normal AFP. PR was any tumor shrinkage, and a 1 log decrease in the AFP levels. Stable disease was no change either in the AFP or in the volume change, and progressive was whenever there was an unequal increase in the tumor or in the AFP concentrations. And what we found with this superpladotherapy is that outcomes of, they categorize this as T-Tex4 only, as distant mets, or as annotation factors positive, or AFP. If you look at the overall survival, the children with AFP less than 100 are doing the worst. Their survival is only 33% compared to the other groups. The best has been with the annotation factors positive. And distant mets, also the children, the survival has only been 63%. And this decrease in AFP was probably because of the undifferentiated tumor histology. And so they came out with this study of SIAPEL-4, which was a single arm trial. It was not randomized, but the outcomes have been found to be superior to the historical controls. And here what they've done is in cycle A, they've used cisplatin weekly. So it's given for 8 cycles. Every weekly you give cisplatin and 3 cycles of doxorubicin followed by surgery. And when you assess the child after cycle A, you find the child is still not operable. You can go ahead with cycle B, where you give dox 2 cycles and carboplatin 2 cycles, and you assess the child for surgery. If the child has received the surgery,
we have less time, so
okay.
Yeah.
So this study showed that the 3-year overall survival was good enough at 83%, and this was considered to be feasible. So according to the recommendations, standard risk is monotherapy, high risk is superplado, very high risk is dose intensive weekly cisplatin dox. COG protocol uses either of the combinations, cisplatin dox or cisplatin 5-FU vincristine, and cisplatin 5-FU vincristine has found to be less toxic. So next is the hepatocellular carcinoma, rare in children, only 1%. It is not a very good tumor to have. It's postulated to be secondary. It has an inferior response to chemotherapy, and surgical resectability was also very difficult. And the fibrolamellar variant does not do well. The AFP is elevated in approximately half of these cases, and it usually metastasizes to the lungs and the lymph nodes. And drugs have chemotherapy drugs, they don't have a very little impact, and sorafenib has been tried, but only in adult patients. There are a lot of other tumors like undifferentiated sarcoma, biliary rhabdosarcoma, angiosarcoma, rhabdoid tumors. All these tumors can also metastasize, like neuroblastoma, Wilms, they all can metastasize to the liver, which should be kept at the back of the mind. Biliary tract rhabdomyosarcoma, usually seen in children less than 3 years of age, presents more with obstructive jaundice and mimics a choledochal cyst. Now, next is hepatic angiosarcomas. They are very rare, high-grade malignant neoplasms, account for 2% of liver tumors. They can metastasize to the lungs, which is usually seen. And it's always important to do an open wedge biopsy to avoid bleeding in these children. Even after all therapies, multi-agent chemotherapy, surgical resection, radiation, liver transplantation, the prognosis is poor. Next is, I would like to stress on malignant rhabdoid tumors because they are hepatoblastoma mimics. The only thing they have the same clinical features, like they are present more in males, they have thrombocytosis, they have anemia, they come in a younger age group. But the only thing is that AFP level is usually normal. And when you do the histopathology, the IHC on these tumors, the INI1 BAF47 protein is absent in these tumors. And that's how you differentiate them from hepatoblastomas. The hepatoblastoma, small cell undifferentiated histology can mimic, but the IHC is what comes to our rescue. Undifferentiated embryonal sarcomas, they are like, you treat them like sarcomas, very rare in children, but we have one going on right now. The IHC will again point out to what they are, and the treatment is usually VCIE, which is the sarcoma therapy along with surgery and radiation. Metastatic neuroblastoma should not be forgotten at the end of the day. And so my take-home message would be that the most common liver tumors should be differentiated by age. We know that the congenital hemangiomas and all that are come in a younger age group of less than 6 months to 1 year. So is the case with hepatoblastomas, but hepatoblastomas are chemosensitive. They respond well with surgical resection. Those who have a good surgical resection have a favorable prognosis. AFP is the one which helps us in monitoring even after surgical resections. Hepatocellular carcinomas occur as de novo tumors, but they don't have favorable outcomes. And complete surgical resection is central to achieving favorable outcomes. The Pediatric Hepatic International Tumor Trial is trying to improve the hepatoblastoma and pediatric hepatocellular carcinoma results. And so they're risk stratifying to improve the outcomes. Thank you very much for your patient listening, and I'm sorry for taking more time.
That's okay. I think Dr. Sajid, sir, you can share your presentation. Dr. Priti, you'll have to stop share so that he can share his screen.
Yeah.
Is it visible, Monica, now?
Yes, sir, it is visible.
Screen. Yeah. So in best interests of time, I would start. I'll stick to only the fundamentals of liver surgeries. The most important components which are
So it
required.
is not full screen yet.
It's not?
No,
Mine
sir.
is a full screen.
I can't see it. Why? No.
No?
No. So you can share screen or maybe again.
Stop share. I'll reshare again. Share screen. Share. Are you able to see now?
Yes.
Full screen?
Yes, sir.
Okay. So before you go ahead with surgery for liver tumors, the three important components are that you should be well aware with the radiological anatomy. Forget about the tumor. You should know the radiological anatomy of the liver, the normal anatomy, which is the Connaught segments of the liver, and most importantly, the pretext staging. All these are available on the internet. These are the different segments of the liver as seen on radiology. These are stuff available on the internet. You can very well go and you can train yourself in by seeing normal livers and try to identify the different segments. This is low, which is you can easily remember with that fist position, the different segments of the liver, which are the Connaught segment, and the pretext staging. This is how the pretext staging is. Everyone knows very well that one sector involved, two sector involved, three sector involved, all sectors involved that constitute pretext of how it should be. The remaining sectors are free. Two sectors are involved. That's the radiological picture of a pretext 2 hepatoblastoma, a pretext 3 hepatoblastoma, and a pretext 4 hepatoblastoma. Now, this pretext staging is for hepatoblastoma, but it can be used, or rather it is used for all pediatric liver tumor, especially the malignant liver tumors. Before embarking on surgery, you have to remember that this is a very chemosensitive tumor, and chemotherapy only helps in making the surgery easier. So whenever possible, rather in most of the liver tumor, barring a few very small tumor, especially at the edges or in segment 2 and 3, the left lateral sector, upfront surgery can be avoided. Chemotherapy is useful in most of the tumor. After you do your risk stratification by pretext and whole lot of other things, you can risk stratify, and even the standard risks are better treated with chemotherapy first, followed by surgery. The tumor becomes more fibrotic, bleeding is less, and obviously there is an advantage of the micrometastasis. Hepatoblastoma, we know that it's a systemic disease. It is more prone for metastasis, especially to the lung. That also is taken care of by chemotherapy. So as in, if you see the liver surgery in adult, there is a whole lot of investigation which they prefer, because the basic difference is those are unhealthy liver, and for children's with liver tumor, usually they are normal liver. So we don't require a battery of investigation before embarking on surgery. Some of the simple investigation, the biochemical investigation, the CBC, liver function tests, etc., those are only required. The tumor markers, obviously, to see the response to chemotherapy. And we have the post-text staging. Remember, the surgical extent is decided on the post-text stage rather than the pretext stage. So a pretext 3, which becomes pretext 2 after chemotherapy, post-text 2 after chemotherapy, sorry, that will require a partial hepatectomy rather than a extended resection, whichever lobe or whichever sector is involved. The point I'm trying to make is that the post-chemo extent of the surgery decide the extent of resection rather than the pre-chemo extent of the disease. FLR calculation, functional liver residue, is useful, especially in large tumors, especially in pretext 3 tumors. You want to know how much of the residual liver will be there after the resection. So it is always better if you have large tumors, you also have a FLR. FLR calculation is very simple. The radiologist, the interventional guys are able to do with the help of a software, and you get to know the FLR. Now, in children, the FLR which is required, which will allow sustenance, normal sustenance, the extent is different as compared to adults. In children, it is said that even 15% of FLR is sustainable, in the sense that it is compatible with a resection, with a normal life. So, but we don't intend to go to that extent. Usually, working figures, we take roughly around 20 to 25%. If that much liver FLR is there, you can subject the child to a resection. There are instances where even after chemotherapy, the liver tumor may not shrink to the level which we would expect. There are ancillary procedures which we use to enhance the FLR. Some of them are the TACE, which is the transarterial chemoembolization. The portal vein embolization usually was a very preferred procedure initially, but now similar results can be achieved with the TACE, which is simpler as compared to portal vein embolization. That's why our interventional radiologists are preferring a TACE over a PVE. And the last procedure I have never seen, I have never done this, but for the sake of completion, this ALPS procedure, which is a 2-stage resection. The first stage you ligate the vessels, and in the second stage you do the resection. I haven't done any of these things, and neither I have seen that, so I may not be able to comment on that. But there is this procedure which is used for a difficult resection also. There are certain things which are essential during which may help you during the surgeries, except for the first 2. I don't have the remaining 3, but for the completion sake, these are also useful for liver resection, especially when you're doing complex liver resection. Intraoperative ultrasound, not necessary, but when you are playing around the vessels like the hepatic veins, very close to the common trunks or near the cloaca, intraop ultrasound, or when you're dealing with multifocal lesion, intraop ultrasound may be useful. And very complex resection, extended resection, it is always better to have a intraoperatively cholangiogram to identify any bile duct injuries or parenchymal leak, which can be dealt with. 3D reconstruction, virtual resections are good toys for the boys, which whoever is having them, please enjoy. We don't have it. The ICG is the new kid in the block. It is almost used in all the indication. I really struggle to find where exactly we can use in liver, but people have used it for identifying the cut margins, positivity, to identifying multifocal lesion. The experts who are using it, they are very happy with it. We don't have it, so we don't know its utility. But if it is useful, definitely it is available and it should be tried. The incision, it depends solely on the operating surgeon, whichever incision he is comfortable with, the chevron or the rooftop incision, thoracoabdominal lesion, incision for large lesions which are extending into the thorax, the transverse, and the Makuchiri incision are also available. Once you open the abdomen, you have to assess the primary, see the resectability. Nodal disease, not so common with hepatoblastoma, may occur with HCC. That can be assessed, especially the POTA and the celiac and the SMA. And peritoneal disease, again, it is not common with hepatoblastoma. Sometimes you may have extrahepatic disease lying free, or if there is a ruptured hepatoblastoma or a ruptured liver tumor before the initiation of treatment, you might find some peritoneal disease, but by far it is very rare to have peritoneal disease in hepatoblastoma. The absolute essential step can be divided into three. Basically, mobilization is just part of a routine thing. Inflow control, outflow control, and the parenchymal dissection. These are the important steps in a liver section. The mobilization, usually a good mobilization, dividing the triangular ligaments, dividing the coronary ligament, the falciform ligament. You can bring out the liver completely. You can bring out the liver, let the liver breathe, and you will be surprised that things which were looking too contracted may just open up. A tumor which is pressing on, remember, hepatoblastoma enlarges by pressing. It also invades, but most of it is pressing, in the sense that it is just compressing adjacent structure. When you bring out the liver, actually the liver breathe, and things which are like appearing compact will open up. You may end up with getting more area for your liver transection, especially when you're close to the vessel. So, and this mobilization helps you. Inflow control can be either by selectively isolating the right and the left, or whatever, whichever side you are resecting, the portal vein, the artery. The bile duct is on the operating surgeon, whether he wants to do an intraparenchymal ligation or want to identify before. I usually prefer doing that ligation during my transection. The outflow control, it is not required to isolate the hepatic veins as you proceed with your dissection. But yes, if it is possible to dissect it, you can loop it, don't ligate it. The short hepatic veins, which can be really troublesome, you can just individually take control of them. And for parenchymal dissection, there are so many gadgets available, but the time-tested Kelly Glysis is the favorite, especially my favorite. But we have so many gadgets coming from the adult sides. These are there in the hospital because the adult people are using. We also utilize them sometimes. So we have the CUSA, we can use the ligashore or the harmonic, but the best is the Kelly Glysis technique. And especially when you're deeper inside the parenchyma, the Kelly is your best friend in that situation, because it helps you to crush and identify the vessel rather than transecting the vessel and the vessel crying and then you cry for taking the sutures. So cheliclysis is very good. It's most oldest and the best way, I would think. But if you have other gadgets available, please use them. The hanging technique, which the adults are very fond of, nothing, it's just IVC dissection, taking care of the short hepatic vein, and then you can loop the right hepatic vein. You can put what is this orange thing called? Vessel loop, and then you can hang it, and this is the hanging technique. So these are all things, whichever way you are comfortable, you can go ahead with the isolation. The extent of resection is very standard: right hepatectomy, right extended hepatectomy, left hepatectomy, left lateral sectorectomy, left extended hepatectomy. There are other surgeries also which come, which will say in the, I have avoided a video in the interest of time. That's the right hepatectomy, the vascular demarcation and the transection and the completed transected right hepatectomy. A left hepatectomy has been done in this patient. A caudate lobe lesion, isolated caudate lobe hepatoblastoma is here. This is obviously after the chemotherapy, and we went ahead with isolated caudate lobe resection. In this patient also we required
Assalamualaikum Majid Sangal desi hatta hada Majid yar dek ho already left hepatectomy shivida
Can
the
you
patient
please
condition
mute
madumara khomni
Mehta?
or goldada chire the right
Can you
side
please
liver
mute
ate then aga home artery varta thrombose the
Mehta?
antimal.
Okay, thank you. So this is an extended resection. Along with an extended resection, a caudate lobe has been resected. That's the IVC. That's the left hepatic vein and the left pedicle seen here. Extended resection like this, I said about the intrahepatic cholangiogram. You can identify this. And the ducts here, you can directly cannulate them. You can see the biliary anatomy, and then you can plan your reconstruction, hep J or whatever the position demands. Now, very important question is, what is the margin? Usually it is a tumor-free margin, but people have numbers, a magic number, 1 centimeter or 2 centimeter, 5 centimeter. But the ideal thing is that it should be a tumor-free margin, and the goal is complete tumor clearance. We will come to that. A microscopic positive margin is not associated with inferior outcome, especially in hepatoblastoma in children. This has been shown in retrospective study also. But remember, the goal should not be to have a positive margin. The goal of resection is always to be having a negative or clear resection margin. This is the other concept what we are using. It is the non-anatomical resection. We don't go as per the liver segments. We go by the extent of the tumor. And these usually are the tumors which are the hanging type of tumor on the inferior segments, segment 5, 6, 4, and 3. These are, or 2. These are the non-anatomical resection. But a word of caution has to be given. Non-anatomical resection is something which is condemned by the adult surgeon for HCC, but you have to remember the basic difference. We are dealing with a tumor which is very chemosensitive. Their concept of dissemination of tumor while transecting in a non-anatomic way is not holding to us. There was no study, rather the only study which was addressing this issue also condemned non-anatomical resection. But if you look closely in that study, it had several flaws. But this concept was being propagated by the stalwarts in all the publication and the review article that non-anatomical resection should be condemned because it is associated with positive margin, inferior outcome, high recurrence rate, high complication rate. But no one tried to look at what study. We have believed in this whenever it is possible to do a non-anatomical resection with clear margin, it should be tried. But for that, The criteria are that you should have a good radiological staging of the disease. The patient should have received chemotherapy, preoperative chemotherapy, and you have enough facility of doing the parenchymal transection safely. Now, these are some of the example of non-anatomical resection, the hanging tumor, which I was talking about, away from all the vessels. And some more examples, segment 5, 6 are the commonest. Segment 4 also we have done resection, the parenchymal transection, whichever way you are comfortable. This is a CUSA we are using, whichever way you are comfortable, you can use that. Some example of non-anatomical resection, this is segment 5, a 6th lesion, and this is the marking, and we have resected. This is the defect. So much of the right lobe has been preserved with non-anatomical resection. The important thing is that you should be convinced that yes, negative margins are possible and the tumor should not be extending towards the vessel or the porta. So these again an example of segment 6, 5 and 6 lesion, and this is their resection. A straddling tumor 4B and 5, this would have required an extended resection, either a right or a left, whichever way you want to see. This straddling lesion can be dealt with a non-anatomical resection. See the negative margin of the normal parenchyma all around. So non-anatomical resection is feasible, and we have already published our results about non-anatomical, the feasibility, the safety, the complication, the outcomes of non-anatomical resection and anatomical resection compared limited to the pretext. Also we have sorted our patient according to that, and there was no difference in outcome. So non-anatomical resection in carefully selected patient is possible. Then you have the concept of multifocal hepatoblastoma. These multifocal hepatoblastoma means they are separated by normal intervening liver parenchyma. They may be confined to one lobe. When we say it is a unilobar multifocal hepatoblastoma like this patient, or you can have contralateral lobe lesion like these patients, which is bilobar multifocal hepatoblastoma. If you would see them on the operating table, the multifocal hepatoblastoma will appear like this. This is an example of a unilobar multifocal hepatoblastoma, and this can be dealt with a conventional partial hepatectomy. We had an interesting observation in the multifocal hepatoblastomas. The multifocal hepatoblastoma, if they disappear on after chemotherapy, it is essential you remove that segment also, because we found that when the disease had disappeared and you left behind that particular segment, like if it was a pretext 3 and it became pretext 2, we did a partial hepatectomy instead of an extended resection, there was high incidence of relapses. So multifocal hepatoblastoma has to be treated little aggressively as compared to the unifocal hepatoblastoma. There are potentially the word potentially unresectable tumor. In this case, extensive multifocal, or you have central tumors, or when there is venous vascular invasion which persist even after chemotherapy. In these patients, these are maybe considered as unresectable. But I said these are potential in the sense that central hepatic tumors are not a contraindication for resection or an absolute indication for a transplant. You can still go ahead with a median or a mesohepatectomy. Even with extensive multifocal, I'll show you. The point here I would like to make is that don't look at your medical colleagues to ask and give them more chemotherapy so that the unresectable becomes resectable. Rather, you are inviting problem by continuing the chemotherapy. So if you are not able to decide about the surgery even after adequate chemotherapy, it is time that you pass on the patient to someone who can do it, either a transplant surgeon or a surgeon who can do extensive liver resection. This is an example of a median hepatectomy. Segment 4, 5, and 8 have been removed. Another example of a median hepatectomy, vascular extension, you can take control as shown here and you can do a thrombectomy. It's not a contraindication, provided there is no cavernoma here. This is a portal cavernoma, what you're noticing here. This portal cavernoma, we used some fancy stuff which I had got that time. You see, it's like a plum cake. The Nagi Habib forceps had come to us. And even after that, what we do here is instead of a vascular dissection, we do a complete Pringle maneuvers and we can go ahead with a transection. So having a portal cavernoma, it's a challenging surgery, but definitely you can go ahead with a partial hepatectomy even in the presence of a portal cavernoma. Multifocal hepatoblastoma, bilobar, you can do an anatomical resection on the worst side, and you can do either just non-anatomical resection or coring on the multifocal side. So even multifocal hepatoblastoma, I said that it is a potential, because transplant is the ideal thing, but usually it is not possible in most of the cases. The liver transplant, I'm sure Ashok is going to speak on this. I'll just briefly, I'll tell you, liver transplant is something which is not very simple procedure. There is a lifelong immunosuppression. There are complications associated with it, and there may be an issue, though less with the lifespan of the transplanted liver, but there may be some issue which Thorat will highlight in his talks. So these are the absolute indication for what I feel is for liver transplant in hepatoblastoma. And obviously, when the transplant is not available, we have tried in some of our patients these modalities, very few of them, because invariably the outcomes are bad. But if you don't have the possibility of a transplant and there is a need to do something, radiation also have been tried, but that's not the standard treatment what we use. But even TACE has been utilized in some of these patients. Thank you very much for your kind attention. I hope I have completed in time.
Yes, sir.
It was fantastic, sir. Yeah, I'm going to talk about transplant in a very brief part because Monica asked me to talk in general about extended resection. So, and I was in liver transplantation just 2 days back. So I'm like, actually I don't have to talk because you talked everything. So I will just, so probably just forgive me. But some slides, they are like basic slides because she told me there'll be some resistance or something. And I also have step-by-step picture of hepatectomy, donor hepatectomy. So I will mix all these things. I can, because when we do malignant surgery, basically we both are on the same car. Whatever point you told, I completely agree. But now probably some slides will be very basic and something, but it is in between. I couldn't get much time to take all my photographs, unfortunately. So whatever way I'll proceed, please, bear with me. So I will share my screen. Share the screen.
So the green button in the bottom. Yeah.
Okay, can you see it now?
Yes, you have to make it full screen.
Okay, I'll make it full screen. I don't know because I'm using this MacBook. Is it okay now?
Yes, it is okay.
Just a minute. So I'll just briefly go through it. First, there is my one friend from Pakistan, Dr. Kalim, has joined this discussion. He himself is a liver transplant surgeon, HPV surgeon. Dr. Kalim, if you're hearing me, thank you so much for joining. And also Dr. Vineet and Dr. Tata have joined. So welcome. And this is going to be just a basic lecture, or just like, my topic is very mixed: extended liver resection, principle of liver resection, general consideration, role of liver transplantation in unresectable liver tumors. So she already introduced me. I'll just briefly proceed through the next slide. So before I begin, I must thank you to my mentor, my professor, one of the best liver transplant surgeons and surgeon in the whole world, one of the big, biggest professors in the world. The above picture 2013, when I had just joined him for the masters, and I visited my professor last month. So we both almost same. So my professor always used to say that no journey is free of dangers, no surgery is free of risk and complication. But what really matters is choosing right path, technique at right time. That will virtually eliminate all possible risk factor. So this is what my professor's teaching. Thank you so much, Professor. So as you know that regenerative capacity of liver forms the basis of modern hepatobiliary surgery. We can cut the liver because we know that liver can regenerate because this is the only organ where cut and regenerate. So our every activity in terms of liver surgery depends upon the inherent capacity of the liver for regenerate. So fortunately, I was also in Athens brief time during my training period. So this symbol used to be there everywhere. So you all must be knowing story that one person, he was, the eagle used to come and bite him and liver used to regrow again. Anyway, so this is the background, I'll just run through the slides that everybody knows. Nowadays, so today's 75% of liver resected. You can safely leave 25% of the liver. So when it comes to liver, as Professor Qureshi is here and my friends join here, that in liver, the size of tumor, it doesn't matter. What matters is how much liver you're going to leave. As long as 25% of the liver, when it's completely normal, and if liver has mild CLD, I would say 30 to 35% of the liver, mild cirrhosis more than 40 to 50% liver, and a patient having gross cirrhosis, and only you can just do enucleation of the tumor. But in those cases, liver transplantation is always a better option. So this anatomy, everybody knows the anatomy. I'm not going to go through it. So basically what everybody knows, liver is only one. The only way we cut the liver anyway, as per whatever boundaries we have inside our brain, and we are mapped inside our brain, but actually you cannot see. When you start cutting liver, you do not see anything. So for that, people who are getting trained in liver, always remember liver is only one liver. There is no right liver or left liver. We have divided into a surgical thing. So for that, you must see all the venous drainage, which is very important. Before every surgery, you must know all these draining veins, and every vein has particular name. Every single vein you have to identify, then only you can go for segmental resection. Many people call it non-anatomical resection. What I call it segmental anatomical resection under ultrasound guidance. If just last week I did one surgery in 62-year-old person where under background of CLD, the right heparectomy wasn't possible, and it was at the right perical bifurcation, right ancient right posterior tumor was sitting exactly between that two. So in that case, I had to not only save the segment 5, segment 8, and segment 6 and 7, but I had to remove the segment 5 bearing the tumor. In that case, intraoperative ultrasound really helps. So you can continually use it. Which are the draining veins to the segment 5, where is the perical, where is the inflow. So even segmental resection can be done in anatomical way, but for that you need intraoperative ultrasound. As Dr. Qureshi in his lecture mentioned how important it is for all the budding surgeon to learn, and every liver surgeon should know, intraoperative ultrasound by himself. For that, I think you should see minimum 50 to 100 CT scan of the liver. Then only you'll know which are the segments, how the veins are drained. So it is divided by the hepatic veins. The posterior, in the lateral side of right hepatic vein is the posterior sector, which is segment 6 and 7. Between the middle hepatic vein and the right hepatic vein lies the anterior sector, that is segment 5 and 8. Between the middle hepatic vein and the lateral ligament, umbilical ligament, lies the segment 4, segment 4B and A, which has got two distinct veins, and then lateral left part of the umbilical ligament is segment 2 and 3, and caudate lobe is 1. So this is usually the anatomy. If you know the venous anatomy and the inside the vasculature at the porta, then surgery becomes easy. So I'll go, this is functional surgical anatomy. I'll run through the slide. So Brisbane terminology, when there were lots of terminologies, and especially if everybody would agree that eastern side, because they are pioneering the liver work, so their definitions, so fortunately I learned in Taiwan. So in many anatomical definition or surgical definition, little varies as compared to Western world. So many times, when I say something, you might be doing the same way, where probably you might have named it in different way, because throughout my career, everything was in the eastern side, in Taiwan, Korea. So they have got their own way of calling it. So sometimes I use some words, please forgive me. So this is usually Brisbane terminology to standardize the thing. different nomenclature. In 2000, they have given the names of first order division, as you know. Right hepatectomy means segment 5, 8, 6, and 7 without MHV. So with MHV, when you take it, it calls extended right. So anything beyond that extent called extended hepatectomy. And in our definition, trisegmentectomy, trisectionectomy, in right trisectionectomy, when you do right hepatectomy plus segment 4, including the inflow of the segment 4, then only it will be trisegmentectomy. If your only left side of middle hepatic vein is extended right hepatectomy, because segment 4, even though it's half, still preserved because inflow is preserved, so it will regenerate again. So same right hemiliver, right liver, left hemiliver or left liver. Second order division, please take the screenshot. I'll just run through it. Anterior sectorectomy, posterior sectorectomy. So anterior sectorectomy, it has got biggest cut surface because you have to go on the both side, on the right side of the MHV and on the left side of RHV. So you have to go, and when in this glycerine pedicle approach is helpful, because when if you are seen very closely, when the right pedicle goes inside the liver, you have to do slight 1 or 2 5 millimeter to 1 centimeter hepatotomy. That time you will see the division of the right pedicle into right anterior, right posterior. So you can individually take right anterior, right posterior pedicle. So if you can take that one, then you can do anatomical anterior sectorectomy by taking control of that particular pedicle. So this is when you see 5 and 8 is anterior sectorectomy, 6 and 7 posterior sectorectomy. This is segment 4 or left median section and left lateral section, everybody. Same thing, segment 4, trisectionectomy or extended right hepatectomy, what they're saying, or extended right hemihepatectomy. Third order division, again, Dr. Qureshi already did my something helpful to me, the images of tumor bearing segment 6 and 5. So because it is the pedicle, it lies the lateral side. So whenever you do segment 6 resection, basically I won't call it non-anatomical resection, because whenever it is on the light side, hanging tumor, it is always segment 6, and the inflow is very particular, outflow is very particular. So whenever you cut segment 6, more or less, though we call non-anatomical resection, eventually you cut only segment 6. And when you do 5 and 6 together, so again, that time Glyconian's approach helps you. I better, like, if anybody trying that, my suggestion would be, rather than going blindly from the parenchyma, first do hilum, take complete hilar control. Monica was there with me last surgery. So first you take complete right hepatic, just like you do by right hepatectomy, take right pedicle control, then go up, do hepatotomy, then you'll see right posterior, right anterior. That time you can take individually right segment 5 pedicle, and segment 6 pedicle is ideally, it continues like that. So when you do transection, on the way you can transect segment 6 pedicle. Because sometimes in living donor liver surgery, we do take posterior sector as the, if size is the problem, we take posterior sectoral graft, which is very difficult, very challenging, but still can be taken. And this is again same thing. These are different varieties of resection. But preoperative consideration, CT scan, triphasic CT scan. What I want is triphasic CT scan. First thing, see the tumor location. What is the relationship? The inflow and the outflow. That is the hepatic vein. Which are the hepatic vein draining? Whether you are doing right hepatectomy or left hepatectomy. Accordingly, you must study the hepatic venous anatomy, because that will decide your surgical success. And then all the necessary, remaining thing. MRI, basically, I don't need it. I'm more, like triphasic CT scan images. And my habit, Eastern habits are that now, as you see that Dr. Qureshi mentioned about 3D printing, it was started, I think, 8-9 years back in Taiwan. But what we used to do, we used to draw the actual images on paper. And then when you start doing resections, and you'll find more or less same picture what you draw on paper. So knowing the anatomy on the CT scan, the relationship with the tumor, and drawing that actually on the paper, studying it is kind of rehearsal inside your brain, actually going for the surgery. So it is very good habit. Everybody must learn this act of seeing the tumor, correlating with the vessel, and drawing it on the paper. So I'm not going into all these details. You know that resectability, preoperative cancer resectability is a normal liver. You can remove as much as 75% of parenchyma. And in cirrhotic liver, in Taiwan, we used to do ICG test regularly. If ICG test less than indocyanine green test, IB is IB test. So if ICG clearance is less than 14, so you can do major hepatectomy between 14 to 16. You can do sectionectomy between 18 to 20. You can do only up to 3 centimeter tumor resection. More than 20 ICG we generally is contraindicated. So whichever, always remember when you do liver transplantation for any tumor, hepatoblastoma in kids or HCC for adults, when it is not resectable. Whenever tumor is resectable, resection is always the first option. So transplantation is not an option for resection. When patient is resectable, so resection should always be offered to the patient. Transplantation is not a first option for a resectable tumor. It is always unresectable tumor. Now, a 20 centimeter tumor can be resectable if you can leave behind 25 to 30% of the normal liver parenchyma, and even a 2 centimeter tumor can be unresectable if it is grossly cirrhotic liver parenchyma. So liver function defines the resectability of the tumor. Now, future remnant volume. Nowadays, all the CT scan, the volumetry, because in donor, we do volumetric assessment routinely. What is the right side volume? What is the left side volume? There is 3D reconstruction. So you know actually after cutting the right lobe, how much volume will remain. So in donor, because donor is a normal, he's not a patient, he's a normal person. So usually our cutoff point for the donor is 30 to 35%. But if the patient has HCC, the cutoff value goes from 25 to 27%. Sometimes your own wives, like, sometimes you see how much volume on table you think is sufficient. Because last patient, when I was going for right hepatectomy, I thought his volume isn't sufficient. The liver was looking normal on CT scan, but on table, I found that patient having hepatitis element. And eventually after 7 days of histopathology analysis, we found out that patient had background of hepatitis and ballooning degeneration. So that time, though, we went ahead with the plan of right hepatectomy, but on table, we did only segment 5 anatomical resection under intraoperative ultrasound guidance. So future remnant volume, you should calculate, there are volumes, but ultimately, again, you have to assess whether it fits your plan or not. So anesthetic consideration, to minimize the blood is always better, low and controlled central venous pressure, less than 5 millimeter. Hey, just hold on because my computer might go off. I just connected for. I'll connect it to electrical. Just one minute. Connecting. Just give me 1 more. Sorry for interruption. Meanwhile, you can have a sip of cup of tea, which is there on your table, if you're at home. Okay, so good, we're safe. Okay, so anesthetic consideration, low CVP maintain minimum fluid resuscitation agent that promote venodilation. Once the specimen is removed, hemostasis is ensured and the patient is resuscitated to status U volume. Now, operative consideration. Now, again, this is the basic part, so I will just go through that. Appropriate antibiotic prophylaxis. In Taiwan, we used to give only 1 shot of antibiotic, and that's it. But here we give 3 days of antibiotic during any resection. Correction of anemia, coagulopathy, and all these things. Everybody knows what is the preoperative preparation. So preoperative procedure. This is how we do it. So I'm going to share one photograph. Just a minute. How to go ahead there. I want to share. I want to share the. Just a minute.
Is it in the same presentation or a separate share?
On a separate sheet. Sorry. How to exit?
Sharing there it is.
Stop sharing and then go on to the other one.
Dr. Ashok, you'll have to stop share and I think show it.
Okay, so do one thing. I will first finish this presentation and then I'll show you those step-by-step surgery photographs which I had. So these are diagrammatic presentations. So usually what incision is right incision. Usually your exposure should be adequate. What we used to do, right subcostal with midline incision, and right subcostal, basically 4 fingers below the right subcostal. We don't take immediate right subcostal, because when you retract the lower part of abdominal wall, it comes in way. And your retraction with Thompson retractor is quite strong. So when I take the subcostal incision, it's a 4 finger below the subcostal, and then midline is midline extension. For a larger tumor, you may go for Mercedes-Benz. When I visited Japan, they used to a J-shaped incision, but our incision used to be, you can say, half Mercedes-Benz, subcostal with midline incision. Some people take Chevrolet incision. That is also okay. So incision is your own choice. Make sure that your exposure is adequate. You can see IVC, because not all livers are same during mobilization. Sometimes it's really very painful as the liver. Sometimes they are stuck, sometimes because tumor is segment in the posterior segment. Sometimes they are regions because of vascularity to separate from diaphragm. It may cause major blood loss if your exposure is not adequate. So to rotate the liver, to separate it from the IVC, to look the right hepatic vein, these are very, very important steps, and everybody should master that one. When you know to do that one without causing blood loss, then probably the chance you'll be better surgeons. So inflow control, I usually use Pringle maneuver. I tell you that we'll say like how we cut the parenchyma. So Pringle maneuver, usually when it started with like 20 minutes and 30 minutes. Usually think is that how Pringle maneuver, when you know that there is ischemia, the Kupffer cells, these are the hepatocyte protective cell, Kupffer cells, they basically deal with the immunity of the liver. So whenever there is ischemia, Kupffer cell proliferate, they try to protect the liver. So it's got preconditioning. So after 20 minutes, ischemia is helpful, and then 10 minutes you again give time. So I usually do 10 minutes of Pringle maneuver, and 5 minutes I wait for the liver to again get vascularized, and I repeat it. Usually 5 to 6 Pringle maneuver is required, but safely you can use 15 minutes and 5 minutes. I personally use 10 minutes of Pringle maneuver and 5 minutes rest. So as you know, when you open, you first assess what is there, whether you are going ahead with the plan or not, whether they're visible mets or not. And as Dr. Qureshi said, that I also I take the right portal control, right hepatic venous control when I start transection. I do not do any irreversible step unless I do almost 25 to 40% of parenchymal transection. So usually when I am doing right hepatectomy, I would take control of the right complete pedicle. If sometime I take a glyconian approach where the right pedicle completely control in that artery, bile duct, portal vein is together. It is, unfortunately I don't have video now, but I'll show you. You don't have to separate anything. So there is one slight 1 or 2 millimeter margin where the pedicle divided into right and left. That part is avascular. You have to go exactly in that part. So you can completely encircle the complete right pedicle without isolating the right portal vein, right artery, or right bile. Okay. So, but usually, most of the time I do it separately, right portal vein, right hepatic artery. And bile duct, you should never encircle. Bile duct, you leave as it is. So when you will encircle, is always the right portal vein, right hepatic artery. Now you take control on that. You put bulldog clamps, or you just put your sloops that they're rubber thing. तुम्हारा phone है. Hello. Let it be. जाओ. No. तिथं नेटवर्क चांगलं आहे म्हणून ठेवलेलं जातोय. इथं नेटवर्क येत नाही. Okay. Lecture is going on. Please go. Yeah. Oh, sorry for interruption. Okay. So the inflow control, I take it, and then when I start cutting the parenchyma, 25 to 30% or 40% parenchyma is done. When you know that now you're proceeding with that, where you're proceeding with as per plan, and then I do irreversible step. So I suggest people who are doing liver surgery, please do not attempt any irreversible step at the beginning. In that case, you have to complete surgery, because there's 1% chances in your 100 surgery that something might happen in that you have to stop the surgery, abandon the surgery. If you do irreversible at the beginning, you'll not be able to, you have to complete the surgery. So always, this is what I learned. So I'll proceed. So outflow control, there are 3 to 4 different ways of doing heparectomies. First, your usual way, you do Pringle maneuver. In Pringle maneuver, you take the sloop around the main complete porta, and you use either Nelitron with as you know how you do Pringle maneuver with artery forceps and all. One method is complete vascular exclusion. It is very helpful because when you think your tumor is vascular and there is when you do Pringle maneuver, you put bulldog on the right and left, your right portal vein and the right hepatic artery, and I also put clamp on the right hepatic vein. So in that way, now your liver is completely devascularized. Whatever blood it is going to the middle hepatic vein, which is also supplied from the left side. Now, sometimes I have seen that when you are doing transection and there is unfortunate injury to MHV or IVC, in that case, I suggest you to complete clamping of the porta, suprahepatic IVC clamping, infrahepatic IVC clamping. This means your liver is now completely devascularized. At that time, you try to remove the liver affected segment as soon as possible and then correct it, because this cross clamping can be tolerated easily if haven't caused much blood loss or air embolism up to 10 minutes. So you've got 10 minutes when the unfortunate injury happens on the table. So that is called a complete vascular exclusion. Once it happened, when we didn't anticipate tumor was invading the IVC, when we went there, transection was almost complete. Tumor was around the right hepatic vein, but we found out that it was invading actually the IVC. We missed that somehow on the scan. So that time we had to do complete complete vascular control of vascular exclusion, and we resected part of the IVC and reconstructed it. Parenchyma transection, I use as Dr. Qureshi, I use Kelly Crush and use harmonic, but for donor we use CUSA, because CUSA, when you use, the chance of bile leaks are less. But even from my side, from my hands, when you identify the pedicle, for that you have to have pre-op CT scan in detail. You identify the pedicle, you ligate, and I better, whenever there are pedicles, sub-pedicles, you ligate, better to have suture. Do not use clips, because when liver regenerates, clips fall off, they can be the source of bile leaks. And as you know, he already mentioned that Kelly crushing, ultrasound, dissection. So these are the complications: liver failure, hyperbilirubinemia, cholestasis, bile leakage, post-operative bleeding. These are the complication, reproductive ascites, and other. This one. Now, challenges and certain facts. Always remember that the patient with childhood liver malignancy who present with extrahepatic or metastatic active disease at diagnosis that fully clears with chemotherapy and or surgery are still candidates for transplantation. Survival rates after primary transplant are excellent, 80 to 85% 5-year survival. Some have questioned about the role of salvage transplantation performed for local relapse or in case of incomplete tumor resection. Sometimes it may happen that, like there are certain situations. For example, next week we are doing an extended left heparectomy. This patient came with tumor rupture. That time we didn't have much option. We prepared for transplantation, but patient didn't have any donor. He was barred from DDLT listing. So fortunately the bleeding stopped, but that is the time we were panicked that patient might not survive if tumor was about to rupture. Because we couldn't do resection that time, only posterior segment was remaining, and as per he's 16 years old, 50 kg, as per volumetry, his posterior sector was only 19%. In those cases, I know that that tumor will never regenerate. So that time we had planned this, that we'll keep the donor ready, we'll do resection, and if patient's liver doesn't regenerate, then we'll go for sequential liver transplantation. But fortunately for the patient, his bleeding stopped. He survived for 1.5 months. He completed his chemotherapy. Now his tumor has shrunk. Now we're going for extended left heparectomy. For that, transplantation will not be needed. In emergency, you have to be ready for all the options.
Dr. Thorat, I think we have already overshot time.
Okay. So I'll just run through it. So About tumor margins, always remember whenever we cut the liver, we always cut 3 to 4 millimeter of parenchyma. So even microscopic margins are there. This means you already cut 3 to 4 millimeter parenchyma. If there is suppose 1 millimeter margin positive, this means already 4 to 5 millimeter margin positive. If tumor is capsulated, it's sitting on the pericle, that time you may not see the margin, but if you see the long-term survival, there is p-value not significant, survival is quite good. Okay, so these are the we did together. This was tumor. It was invading the segment 5 as well. So we did left hepatectomy, but we also removed the part of segment 5. And then this side we did extend right hepatectomy, and this is our technique. And these unfortunately I had not enough time to give photos, but Dr. Sajid put wonderful photos. So I agree whatever he has said. So whatever photos you have shown, the surgical dissection goes the same way. Only thing you have to be very delicate, very meticulous in your dissection, inflow and outflow, and make sure that you don't. You have to be very careful when you are around the middle hepatic vein, because more than bleeding, air embolism, that is the trouble, which causes basically mortality. So when you think MHV is damaged, that time pour plenty of water, and call for help. Okay, and make sure that you clamp suprahepatic IVC, pour plenty of water, and try to control the bleeding, because more than bleeding, the air embolism, there is a trouble. So again, the same, my professor. So I will just quickly go to the slides. I'll give it, I'll just, a walk in the membrane lane. This is the CMH, China Medical University Hospital in Taichung, which is now number 2nd in Taiwan. And among top 500 medical institutions, there is one is ranked 134th. It's Sister Institute of Kyoto, Sister Institute of MD Anderson, and John Hopkins. So this is our building, and I had privilege to be part of this system for 4 years, and 2.5 years I was in Chang'an, Taipei. So this is our team. This photograph was taken 2015. So thank you so much.
Thank you, Dr. Thorat. Will you allow me to share my screen, please?
Yeah, just a minute. I'll just show you some quick photographs. So this is a step-by-step photograph of the donor. Oh gosh, my internet is a problem. They are very wonderful photographs. You will love it. The step-by-step photograph. Okay, so here when we do donor hepatectomy, we always do cholangiogram. I routinely do not do cholangiogram while doing right hepatectomy or left hepatectomy for the HCC, but it's always a good habit. But in donor hepatectomy, yes, we do cholangiogram before and after the surgery. Sorry, guys.
Thank you. It has been a wonderful session. I had few questions, probably that they have been already answered, but I'll just still share my cases. Is my screen visible?
Yes.
Okay. So first case is a 4 years old male child. He had a normal AFP and beta HCG, and LDH was around 800. So Dr. Priti, would you like to have any other lab investigation for the child?
I missed your first statement.
Okay. So 4-year-old male child with the normal AFP and beta HCG with a raised LDH. Would you like to have any other investigation for the child?
So my AFP is okay. I would like to do an ultrasound abdomen if he has a liver mass or anything. LDH is raised, so probably there is a rapid cell turnover. So an abdominal ultrasound, if there is clinically a liver tumor that is palpable or something, or is evident that the child is symptomatic.
Okay. So, there's a CT scan was done which showed a heterogeneous mass involving all segments of the left lobe and extending into the segment 5 and 8 of the right lobe. Possibility of a sarcoma, and there were 2 satellite nodules which were seen in the right lobe. In this situation, I think you've already discussed. Would you like a biopsy for this child?
Yes, unless there are contraindications where we are suspecting. I don't think we are suspecting a vascular tumor out here. So definitely, if it is suggestive of a solid tumor and less of a vascular tumor, a biopsy would be recommended.
So one of the contraindication is a vascular tumor where biopsy is not required. Biopsy is not to be done. Okay.
Yeah. So if we are suspecting a hemangioma or a angiosarcoma or something, then we would rather not do a biopsy in these children. The rest, yeah.
So this child had a malignant neoplasm, which they did a PET scan also, which showed a hypermetabolic heterogeneous enhancing mass, and they were the discrete nodules. They did not have that much. They were not that avid. So they were thinking in the terms of angiosarc for this patient. They gave 3 cycles of chemotherapy, and I didn't have a pre, but I have a post scan. This thing, I'll just run through it. So this is the main mass on the left side. There were 2 nodules separately seen. One was close to the MHP, which I think have already gone, and this is the other nodule and the main mass. Dr. Sajid, yeah, sorry.
Did you diagnose an agent? Did you do a liver biopsy or what had you done? Or was it just a radiation diagnosis?
No, it was. I don't have that ultrasound picture, but it was decided to do a biopsy. This patient was referred from outside, so probably that it wasn't that vascular, so they did a biopsy for this child.
And what was it, a wedge biopsy or did you do a core biopsy? Or
It was a core biopsy. It was a core biopsy. Dr. Sajid, would you like to tell about the surgical planning? What should be done for this patient?
Didn't saw the images well, but you have mentioned that it is segment 2, 3 and segment 8 also.
Can you show the image again?
Yes, sir. I'll just try to. So there's one lesion which is just close to MHP.
Right, there's something in front also.
Yes, sir. Go here.
Extended left heparectomy.
Yeah. Okay.
I think Dr.
Okay.
Sajid will agree. Like, you know,
Yes, yes.
the remnant looks good.
Yes.
So we did left extended hepatectomy with partial resection of segment 5, which is the lesion was being seen. So Dr. Ashok, is there any role of intra-op sonography for this child?
This child, when you are doing major heparectomy, because you already know the boundaries. When you already know the boundaries, that time intraoperative ultrasound is of no use, but it is a good practice because when, like, you know that there are major vessels which you can see, that can be the good practice thing. Ideally is not required. You will require intraoperative ultrasound when you are doing like segment 5, segment 8 especially. Segment 6 okay because it is a lateral part. Lateral heparectomy is also okay, but you are doing like segment 7 or segment 8 or segment 5, especially when tumor is at the pedicle, that time, yes, it is very much important.
Okay.
You must do it, and everybody must do it. It's very scientific. And in Taiwan, in fact, whenever we open the abdomen, we always check, because it's a high volume center. We do more than 250 to 300 resections a year. So the data says that first thing that once we mobilize the liver, we always do ultrasound and we check. So out of 200 patients, we always see 2 to 3 unexpected tumor lesions which were missed, because intraoperative ultrasound can pick up tumor as small as 2 millimeter.
Okay. So the ultrasound was done post-resection, so they showed no residual lesion in this patient. The HPR report had negative margin, and its separate deposits which were seen did not have any tumor cells. They just were extensive hemosiderin deposits which were seen.
Yeah.
Post-op sonography was normal. So we have another case. I'm sorry, I'm running through the slides. We had a second case, which was 8 years old male child. He complained of abdominal distension, and when he was evaluated, they did sonography. The AFP was raised, and it was the CT scan was done, which showed ill-defined heterogeneously enhancing mass in the right liver, and the biopsy was planned. I don't have the AFP value, but yes, it was raised. So this is the first scan where multiple lung nodules are seen, and this is the liver scan. The child has had ascites plus multiple lung mets. So Anyone can take this question. Role of biopsy and planning of a biopsy. I just have one question in this. With this ascites, do we do biopsies? Is there any contraindication of doing a biopsy in this kind of a case?
I think we shouldn't do biopsy.
The AFP was raised. AFP was raised. Only thing is that he was 8 years old with a raised AFP.
Diagnosis is pretty clear.
To differ, I would, since he's not in the typical hepatoblastoma age and he has mets and all that, I would like to rule out some carcinoma in this child. Probably hepatocellular carcinoma. We don't have the AFP level. And if it may not be that raised like a hepatoblastoma, I would want a biopsy in this child.
Okay.
Unless the surgeons have something else to say.
No, if you think that is required, because will it change the management? Like, that is my only question. If we're changing management,
Absolutely. Because what are we dealing with? Are we dealing with a hepatocellular carcinoma? Are we dealing with something else, some other tumor? Is what we need to know. So,
you must
not doing a biopsy is not going to lead us as far as treatment, further treatment is concerned.
then okay, it's acceptable.
Dr. Sajid, do you have any point to make on this?
So, Monica, this is even if it is the age is towards a side of which is HCC, the commonest tumor still in children would be an hepatoblastoma. And the HCC in children is different from the adult in that it has some amount, not to the extent of hepatoblastoma, it has some amount of chemosensitivity. So even with this extensive disease, metastatic disease with ascites, what is the cause of the ascites? We don't know. But the first treatment definitely here will be non-surgical. And even if it is HCC, there is a chance for offering this child chemotherapy, which doesn't differ much from the hepatoblastoma chemotherapy. We go ahead with the superplado regime with the HCC also. So there is a case of going ahead with chemotherapy. Biopsy plus or minus in presence of ascites, biopsy is contraindicated. But if you are hard pressed for getting some tissue diagnosis, you can try from the lung. If the lung lesions are quite big and there is no effusion, biopsy can be done from there. But the treatment in both the scenario remains the same. So we can err on the side of being a hepatoblastoma and go ahead with the chemotherapy because chemotherapy is not going to differ. So I would not fret so much about getting a tissue diagnosis. I have an liver mass with metastasis and with raised AFP. There is enough indication for me to go ahead with the next subsequent treatment, which we think this should be chemotherapy first in this patient.
Okay. So for this child,
Can I add something, Dr. Monica?
Yes,
So
please.
2 things. The first thing is that in any hepatoblastoma, if the child is more than 3 years old, a biopsy is required. That is what the guidelines say. So that is one thing. And secondly, hepatocellular carcinomas, even if we are giving the same chemotherapy, they are not very responsive to chemotherapy. And a surgical resection is what would be better off in these children with hepatocellular carcinoma.
Okay.
So I think I would beg to differ from Dr. Qureshi on points.
No.
If you go by the adult standard, this is an inoperable case, palliative case with a metastatic HCC. We don't treat pediatric HCC in the similar lines of adult HCC. They do not respond to that extent, but definitely they respond to some extent the pediatric HCC. And here in this situation, we don't have much to offer. We cannot go for a definitive resection, even if it is like HCC, if it is proven. With ascites, with so much pulmonary metastasis, what are we trying to achieve? So the best scenario in this patient would be going ahead with chemotherapy. And it's not that it will not respond. It may respond. I'm not saying it will respond. It may respond to chemotherapy and give us time for things to improve. Maybe the pulmonary meds may improve. Maybe the ascites may improve. And we can plan for the next treatment.
Okay, so basically the age criteria was to go for biopsy, but ascites the biopsy can be avoided. And since the AFP is raised, I think we can go ahead with chemotherapy. And as far as I know, almost both these cases, they have similar kind of a chemotherapy. The outcomes obviously vary. If I'm correct, then so we did. So Dr. Priti, what would be the staging and the risk stratification for this patient? It was a pretext.
This
All
is
lobes were involved.
metastasis, so it's pretext with annotation factors. So it's definitely a high risk. And I mean, I think on a biopsy and it's saying embryonal pattern of blastoma in your previous slide. So it's like if the child is good nutrition and all that.
Your voice is breaking in between. I'm losing your voice.
I would want to start the weekly cisplatin chemotherapy, and if I think to chemotherapy, but if I think that the child is not nutritionally so good, I would prefer giving him alternating cisplat carbo. That is what I would go for.
Okay. So I lost your voice in between, but yes, the child was given chemotherapy, Cyapel 3 high risk protocol because of the high risk features the child had. So AFP trend was decreasing, but are you happy with the trend, kind of a trend this child has?
No, not really. So there is no single log. There's not even a single log reduction as far as I can see.
Okay.
So I'm not very happy with the response. And then probably this child would have done better with the Cyapel 4, where they are giving weekly cisplatin with doxorubicin, 3 cycles, So I would have probably preferred that.
So Dr. Sajid, Dr. Ashok, is there any reason for AFP not falling?
No, I don't have much insights in that. Probably resistance, probably tumor biological activity is very strong.
Okay.
That
Dr.
is the
Sajid.
only way.
Okay.
Yeah, it's a metastatic disease. There is a fear that this could be an HCC also. So yes, things are looking that bad with the evidence we have.
So you
yeah, it may be.
Okay. So this is post chemo scans. Lung mets have slightly come down on size, but not a great. The numbers they have are almost the same. I'll run through the scan also. So it was pretext 4, but now it has become pretext 3. There's a slight just the portal vein over here is just close to the tumor. So it has become pretext 3, but lung mets are almost same in number, but size has slightly come down. So sorry, I think so Dr. Sajid, what would you say now? This is post chemotherapy scan. So what should be done?
So it was pretext 4. You said that pretext 4 was multifocal, or it was a solitary pretext 4?
So it was solitary.
Okay, so we would go by the post-text extent, and it has come to post-text 3. Definitely an extended resection should be processed. And regarding the pulmonary mets, first a clear look at the pulmonary mets, how many are there, how far they are there, and are they resectable. Only if the pulmonary mets are resectable at this stage, we should think of the primary. Now, one can debate that we should clear the pulmonary mets before we go for the pulmonary resection, before we go for the liver resection. That's fine. Whichever way you want to go, you can go for that. If you're going for a transplant, the pulmonary mets needs to be addressed because you should have no extrahepatic disease before you go for the transplant. But transplant is not the case here. We are going for a partial hepatectomy and extended resection. Definitely, we can go ahead with the liver resection. But if someone say I have to do the pulmonary mets first, get an R0 status there, then only I'll go for the liver resection. He is justified in saying that also. So whichever way you like to look, it is correct.
So the picture might have not captured it,
I
but there are
agree.
now 9 to
I
10,
agree
9 to
with
10
exactly like
nodules on both sides.
pulmonary mets should.
So the numbers are high actually. There are around 8 to 9 on both the sides. So
8, 9 on each side. That means
Yes, sir,
18,
yes.
19, 18.
Yeah, I think so. Because on one side they were 8, the other side they were 9. I've not taken the full picture because I couldn't do it. But if you see this coronal section, you can see these nodules which are on the posterior side, most of them.
Monica, there are central lesions also in
Yes, sir.
the upper right. Now, central metastases are very difficult to resect.
Yes,
They
sir.
may require lobectomy or pneumonectomy. And I
Yes,
could see in both in the upper right picture in the small axial sections,
yes,
HRCT, there are 2 on both sides.
Hmm.
Yeah, this is a very difficult situation, Monica.
yes,
This
sir.
is a very difficult situation. The Mets, peripheral Mets are quite a few. They are small, but there are quite a few. We can see at least 4 on the right and 1 on the left. Those are peripheral. Those are easily manageable. But the one in the center are not easily managed. So the pulmonary Mets seems to be many, though they are technically resectable, but it is going to make the child pulmonary cripple also, addressing so many metastases on both sides. And obviously, there is always a possibility what you're seeing 5-year may turn out to be 6 or 7. More commonly, it happens with OGS, but it can happen with any solid tumors. So that possibility is also there. So achieving an R0 status in the lung is a question mark, big question mark. You can try if the chemotherapy is not completed yet, in the sense, how many cycles have been given? You're on Soprano.
Four cycles of this thing.
Usually by 4 we have got enough response, and we have started operating after 4 cycles only, because we have realized that if we continue for 6, which is the standard recommendation, that you give 6 and then go ahead with the primary surgery and then give the remaining 4, by that time, but the 6th time the AFP starts rising, and in your case the AFP has not normalized or had a good log reduction. So again, these are all red flags.
So we have planned further giving him chemotherapy, probably changing or what the medical oncologist will decide. So
this is the best time. This is the best window to do that.
Okay. So to do what? Surgical resection of the liver or what?
No. Best window for your,
Okay.
because here this is things are going to improve or not. I am not certain, but definitely it is not a suitable time for the surgery, because you will be the AFP is still high, the liver lung mets are still persistent and not amenable for resection.
Absolutely agree.
Okay. So ideally it is to clear the lungs and then go for the liver surgery.
Yes. Otherwise, surgery of no use, because it's already flourishing, and you never know where it is reached outside of the lungs. It's a disease already systemic.
Yeah.
We consider it's only limited to lungs, and lungs must be clear, because clearing liver disease won't help.
Yeah. So I think the next 2 questions have already been answered. So I'll just skip this. Role of liver transplantation is also been answered.
No, I think if suppose pulmonary mets are cleared, suppose pulmonary disease is addressed, the liver is completely resectable, looks resectable. Transplantation only if resection is not possible.
Okay. So Dr. Ashok, we have already discussed about the role and when the patient should be sent for the transplant team. What do you think is the right time the liver transplant surgeon should be involved? Is it once it is decided that it is difficult, or as soon as the patient comes and there are signs, there are radiological signs that child might require a transplant? What is the right time? What
I think like when at the time, the right time is that whenever you see the tumor and you know that resection not possible, or it is on the verge, only that time it is better that you should be talking to the transplant team and let the donor keep ready. Like when you know that resection is definitely possible, but still I think is a multidisciplinary approach, and most of the places that liver transplantation team is already involved in liver surgeries. Whenever you know that is a major tumor and your resection not possible, when you see the patient, that is the time it is better to counsel the patient. You may require transplantation, and one counseling with the transplantation team and donor in future donor vary, and you can still try liver resection, that what I call is sequential transplantation.
Okay. Dr. Sajid, there's one question. So normally you said you give 4 cycles of chemotherapy and then plan for a surgery. For a difficult liver tumor, is there anything that you give 2 cycles of chemotherapy and then do a scan to decide whether is it still under a transplant or a regular resection can come down?
That we have to decide right before the chemotherapy itself. You
Okay.
should not decide midway that this is
Yeah.
not going to be resectable. The
Okay.
transplant planning should should start right at the outset. Like if it is a multifocal hepatoblastoma, be it a solitary or several lesions are there. Multifocal hepatoblastoma, you should basically understand the entire liver is diseased. And there is a case for replacing the entire liver. You don't want any abnormal area. So the preferred treatment for a post-ex or a pretext 4 is a transplant, whether they shrink or not, the preferred treatment. It is only our convenience that we are hoping that it regresses and we'll be able to do a partial or extended resection. So the decision that this child is going to eventually require a transplant has to be taken at the outset, like extensive vascular thrombosis, portal cavernomas. Those situations you should decide, and the planning should start with the transplant surgeon right when you're starting your chemotherapy, rather than taking a midway decision.
Yeah.
So basically, for every liver resect tumor which looks difficult, the transplant team has to be involved from the start. So
I
that
think that's the idea of an MDJC,
Yeah.
that you have all the players there and you take an informed decision with your medical colleagues, with your transplant colleagues. Everyone should be part of the decision making.
Yes, sir. Thank you. I think that was the last question. Thank you, everyone. I'll just see if there are any questions in the from the audience. I hope every question is answered.
Some of the questions I answered while I was listening to Dr. Sajid. On his behalf, somebody wanted to reach out to Dr. Sajid that they wanted some slides from you. So on your behalf, I answered that the question probably hasn't read that.
Okay. So I guess all questions are answered.
Dr. Shalini Mishra had put her hand up.
Okay. Dr. Shalini, would you like to say something?
No, I just wanted to ask about the plado chemo for pediatric HCC. Would you give that, Dr. Sajid sir, would you give that even if the AFP is not raised?
We have histological evidence that this is an HCC. In that situation, yes. If it is technically difficult, then yes, chemotherapy is to be sought after. If it is a resectable HCC, non-metastatic HCC, then definitely, as Priti mentioned, that surgery is the treatment of choice for HCC, even if in pediatric HCC. But
so also, I would like you to share some literature about that.
Sure.
I'll do that on WhatsApp.
The SIAPL studies also had quite a few HCC in them, and even the current FIT study is also having a separate HCC windows also.
Yes, sir.
So there's one question. Is there any role of radiotherapy in hepatoblastoma?
No, not really. We give we know that it is not a treatment of choice. It is just because we don't have anything left, and it's on the insistence of the parents, a large mass causing discomfort. This is hepatoblastoma treated by radiotherapy? The answer is no. But when you don't have anything, your chemotherapy is not working, it's a surgical relapse, or any reasons that transplant is not possible, non-affording, any other issues. In that case, we have tried in few, but we would not advocate that in inoperable or recurrent tumors, you should go ahead and give radiation to all, because we don't know the answer. There have been some responses in our patients we have given, but the numbers are so few that we cannot recommend anything that radiotherapy is the treatment for unresectable, recurrent, and so on, hepatoblastomas.
So there's one question. What is the embolization of the needle tract? I mean, probably is the embolization done of the needle tract? This is a question. I don't know.
No, I have not heard of it, and
yeah.
So I think it's for the biopsy.
It was written. Sorry, it was written in Dr. Priti's.
Absolutely, and that question is actually for the surgeons. Because
Okay.
No,
I
what
Okay,
got
when-
means
on
is
internet and I didn't understand it myself. And so I was supposed to ask, but I would have asked Dr. Sajid
when
later.
the neural tract, this means
So
disease is
maybe Dr.
outside
Sarin,
of
you can help
you have
me
to
with the
resect, you have to
answer.
resect it. In his
Huh?
neural tract containing
sir.
malignant cell, you have to resect that tract.
So
The
can I
Prof can
answer?
check.
I think that is for the biopsy. When we do a biopsy and there is a lot of bleeding, they put the glue in the needle tract to just to stop the bleeding. That is what I
Yes,
understand
yes.
of the embolization of the needle tract.
Okay, okay.
The
Yeah.
IR people, they do it, the intervention radiologist.
Okay.
So I think all questions are answered. Any
No,
comments from anyone?
one more question I had.
Okay, yes, sir.
I mean, we were talking about multiple myths and all that, and sure, in osteosarcoma we go in and excise so many, but is there any number? I mean, most of the malignancies that I treat, I would say if there are 3 or less, I will go and resect. If there are so many, I would not touch that. So when we were talking about 18 mets and all that, and we were still talking about metastectomy, I was a little kind of.
Oh, it's multiple meds. At the moment, it's inoperable, I suppose. I
No,
totally
so
agree.
what do you consider as the cutoff?
If it's limited to one lobe, probably you can consider lobectomy. But if it's like plenty of thing, then
I think there is no magic number, sir. That 3 you operate, 4 you don't operate. It is the
Yeah.
extent, the site, the location. If there are 4 or 5 and all are peripheral in one lobe, definitely that is resectable. If there are 5 or 4 scattered in both the lobes, different part, in the center, in the central area, those are not resectable. So number is not the answer. It is that it is doable. We know that osteosarcoma, it is a relatively, the recurrent ones are relatively chemo-resistant, and surgery, even multiple surgeries have been twice, thrice. We have
Yeah, I've seen in Memphis one patient undergoing 17.
Yeah,
So,
so that's different. That because the biology of osteosarcoma is different as compared to here. In our excitement of removing those metastases, eventually we may make the child a pulmonary cripple, which is more disastrous in a metastatic setting rather than with all good intention, we would like to remove all the metastases. But an informed decision has to be taken before we embark on pulmonary metastatic tectomy, especially in non-osteosarcomas metastasis.
Okay.
Ask one question, Dr. Sajid.
Yeah.
Why is ascites a contraindication to do a liver biopsy for the
Okay,
tumor?
so ascites, see, the abdominal cavity is a compact cavity. We do a biopsy and the abdominal cavity, the adjacent structure, they have a tamponade effect. When ascites is there in between, the tamponade effect does not come. So the biopsy tract will keep on bleeding, bleeding, bleeding. That's the only reason for any tumor, not liver tumor, any tumor in presence of ascites. A biopsy is contraindicated because the tamponade effect is not there, and that will be more dangerous. So generally, in generally working principle, in presence of ascites, we look for tissue diagnosis from areas other than the abdomen because of the ascites.
And the ascites, is there a volume? Is it significant ascites or even minimal
Mild
ascites
ascites
or
in the
many
pelvis
ascites?
is not a contraindication. It has to be a decision taken based on the CT scan, how big, how far is the ascites, is it extending on the upper surface? All those things has to be taken into
Okay, so
consideration.
it has to be a
Yeah,
significant
yeah,
amount.
a good amount of ascites.
Perfect. Thank you.
So almost everything is answered. It was a good session. I'll just request everyone to switch on their cameras for a second so that I can click a photograph. And Dr. Shalini, I heard you will try to start early next time. Can I please have your cameras if you're not eating or something?
I'm in my cabin
Oh, okay.
and I'm hungry.
Yes, I am too. Is it Dr. Faiza? Sir, Dr. Sajid, you know Dr. Faiza?
Yes, very well. We recently met.
Okay. Please, I'm requesting everyone to just switch on your cameras for a 30 seconds. That should be okay for me. Okay. Thank you. Thank you. I'm just clicking a photograph. I need good big smiles. Yeah. Thank you. Thank you, everyone. Thank you, Dr.
Thank you.
Sajid. Thank you, Dr. Thorat.
Bye.
Thank you, Dr.
Bye.
Priti.
Hi, Shalini. Hi, Yogi.
Thank you. Thank you.
Thank you, Dr. Sareen, sir.
Well, then, thank you so much.
Yeah.
Bye. Good
We
night.
should have
Thank you,
offer.
everyone.
We have it offer. Next time we'll arrange just for technical aspects because
Yes,
so
sir.
huge to talk. So you should talk about it. There's so many things to talk.
Yes, thank you. Thank you. Yeah.
Thank you, everyone, for giving us the opportunity to host this session. I hope you all had a similar experience. So with all your permission, can we close the session over here?
Yes, yes. Thank you, Momita. Thank you.
Thank you so much, ma'am. Thank you.